We're going to continue our discussion now with the abdomen. And we will start our discussion of the abdomen by looking at the abdominal wall. And within the abdominal wall, we're going to pay particular attention to the inguinal canal, the descent of the testis in the male, and what the mechanisms are for inguinal hernias. Then we'll move to the viscera of the abdomen, the interior of the abdomen, and spend time with the digestive system. And we will do the development of the digestive system and the congenital abnormalities resulting from abnormalities in development, right along with the adult anatomy of the GI tract. And then we will do the kidney and ureters, looking at both the adult anatomy and the embryonic development of those organs. So let us begin by looking at the nomenclature that's used for the regions of the abdomen. The abdomen is typically divided up to as scarpus fascia. So campus fascia and scarpus fascia are both components of the superficial fascia. Now, just deep to that, we're going to have 3 layers, and each one of those 3 layers will have a muscle in it, and those layers are called the external oblique layer, the internal oblique layer, and the transversus abdominis layer. Now, each of those 3 layers has 3 components. 3 different kinds of materials are found in each of those layers, and it's important that we deal with those 3 components one at a time to make sure that we recognize the differences, because as we look at the inguinal region and the descent of the testis, we will have to deal with these different components in different ways. So let's use the external oblique layer as our example, but this will apply to all 3 layers. It is simply a portion of the layer of fascia that covers the entire inner surface of the abdominal wall, the anterior, lateral, posterior abdominal wall, the roof, the floor, the entire inner surface of the abdomen is covered by fascia, which it has as a generic name the endoabdominal fascia. But in each region of the abdominal wall, that endoabdominal fascia takes on a name relating to the structure that it's most immediately in contact with. So since on the anterior abdominal wall, the endoabdominal fascia is immediately deep to the transversus abdominis layer, therefore it's called the transversalis fascia. That's not the same thing as the transversus abdominis fascia, which is the deep fascia of the transversus abdominis muscle. It's another layer internal to that, transversalis fascia. Now, layer 7 I'm going to skip for one moment, and we'll come back to it, peritoneal layer. So this is the layer in which we would expect to find the testis during its developmental stage. But we know that the testis does not remain in the posterior abdominal wall in the extraperitoneal layer. It ends up in the scrotum. So the question we can ask is, where does the scrotum fit into this scheme of layers of the abdominal wall? And what we will find is that the scrotum is in layers 4 and 5, the internal oblique layer and the transversus abdominis layer are fused together. So we can deal with these 2 layers as if they were one layer. So now instead of having 4 layers to deal with, we only have 3 layers. First the transversalis fascia, then the combined internal oblique and transversus abdominis layer, and then lastly the external oblique layer. So let's see how that is going to happen. The testis point at which that happens, we're going to call the deep inguinal ring, and as a result of that evagination of the fascia, that fascia ends up covering the descending testis. And that evagination of fascia that's now covering the descending testis will be given the name the internal spermatic fascia. So the internal spermatic cord. So therefore we can now say that this internal spermatic fascia, this evagination of transversalis fascia, is not just covering the testis, but as you can see here, it's covering the spermatic cord, which has been dragged down by the descending testis. So we've now gotten the testis from this position, in layer 7, and we've gotten it past layer 6 to this position, but recognize that we haven't. And the cremaster muscle, which you see now is covering the spermatic cord, will serve as an important thermoregulatory device for the testis. By contracting, the cremaster can pull up the testis, pull it up higher in the scrotum or closer to the body wall in order to keep it warmer in a cold environment, or when it relaxes, it allows the testis to hang lower in the scrotum so that it can get cooler when it's in a warm environment. As we know, cremasteric fascia. So this layer that's now the second layer covering the descending testis and spermatic cord will be called the cremaster muscle and fascia. So now we've gotten the testis to this point. We're now between layers 3 and 4. And so our last task is to figure out how to get past layer 3. The portion of layer 3 that's seen here in the inguinal region is the external oblique aponeurosis. The external oblique muscle ends much further laterally out here, so there's no muscle in this region. So we just have the external oblique aponeurosis, and of course remember that aponeurosis is covered over by fascia. Well, in the external oblique aponeurosis, right in this region, there is a hole. There's an actual hole in the aponeurosis, and that hole is called the superficial inguinal ring. And so the testis is able to pass through that superficial inguinal ring, but that hole, that ring, is covered over by external oblique fascia, and so as the testis passes through the ring, the hole in the aponeurosis, it evaginates the fascia covering it. So it evaginates the external oblique fascia, and that evaginated fascia is now called the external spermatic fascia. So that's now the third of a structure that should be within some kind of a containing wall. And if it gets out of that containing wall, we call that a hernia. So when we talked about the vertebral column and the intervertebral discs, we talked about herniations in the intervertebral disc, in which the nucleus pulposus, which should have been within the containing wall of the annulus fibrosus, got out of that containing wall. So we called it a herniation of the nucleus pulposus. Both statements are accurate. So what we're saying is all inguinal hernias emerge through the superficial inguinal ring. But what's different about indirect versus direct inguinal hernias is how they got to the superficial inguinal ring. The indirect inguinal hernia goes in the deep ring, runs down the length of the canal, the full length of the tunnel, and comes out the superficial ring. The direct inguinal hernia does not go in through the deep inguinal ring. It tears the region of the abdominal wall right behind the superficial ring through which direct inguinal hernias pass is called the inguinal triangle. This region here is called the inguinal triangle. Often you'll hear it referred to as Hasselbalch's triangle. And that triangle, the three borders of that triangle, the lateral border is this artery, the inferior epigastric artery. The medial border of the triangle is the lateral margin of allow the surgeon to determine whether this is a direct or an indirect hernia, because as you push the hernial sac back up, if it were an indirect hernia, be pushing it back up this way, the surgeon's finger would be following it back up. The finger would end up here in the deep inguinal ring, which would put you immediately lateral to the inferior epigastric artery, and that would allow you to feel the pulse of the inferior epigastric artery. And since you would feel that your finger is lateral to the pulse of the artery, and we know that the deep inguinal ring is lateral to the artery, that would tell you that you're in the deep ring. And since only indirect inguinal hernias go through the deep ring, that tells you that this is an indirect hernia. On the other hand, if this was a direct inguinal hernia, when the surgeon pushed the hernial sac back up into the abdomen, it would go back up this way, the pathway through which it came out. That would put the surgeon's finger over here, medial to the inferior epigastric artery. And this time, when the pulse of that artery is felt against the finger, you would recognize that the finger is medial to the artery, knowing that the deep ring is lateral to the artery, that means you're not in the deep ring, and that tells you that this is a direct inguinal hernia. Now, another useful clinical approach to distinguishing between direct and indirect inguinal hernias can be done on physical exam, not at the time of surgery, but actually on physical exam without having to incise any layers of the abdominal wall. If the physician's examining finger is placed over the superficial inguinal ring, which is immediately superolateral to the pubic tubercle, which would be right about here on this diagram. So if the examining finger is placed on the superficial inguinal ring, and if the patient is asked to cough, therefore increasing intended, but the parietal peritoneum has formed this finger-like evagination, and that evagination of peritoneum is called the processus vaginalis. So the processus vaginalis descends into the scrotum, and then after that has happened, then the testis is going to descend and will basically slide down along the outer surface of the processus vaginalis. So that's what we can see here. Processus vaginalis has already descended into the scrotum, through which structures that are here in the peritoneal cavity could easily slide down into the scrotum. So that would make it much too easy for hernias to occur. So normally what happens is that after the processus vaginalis has descended, and then after the testis has descended, then the proximal part of the processus vaginalis fuses and eventually disappears. So we end up with something like this. The testis is normality. We'll leave this open communication, and since we said that that wouldn't be good because that would allow an easy pathway for hernias to occur, in fact, typically hernias do occur, and these children are born with congenital inguinal hernias. So a congenital inguinal hernia is typically a result of a persistent processus vaginalis, a failure of the processus vaginalis to fuse, and fluid-filled cyst-like structure, and we call that a hydrocele of the spermatocord. So a hydrocele of the spermatocord is a result of incomplete fusion of the processus vaginalis. And so when little baby boys are born with this, when the scrotum is palpated to ascertain whether there has been a descent of the testes, in addition to feeling the testes, you can feel an additional bulge in the scrotum, and it's a fluid-filled bulge, and that is a hydrocele of the spermatocord. So that is a result of incomplete fusion of the processus vaginalis. Let's just distinguish the inguinal hernias that we just talked about with another kind of hernia in the same general region called a femoral hernia. Now on this illustration we can see the inguinal ligament that we already have mentioned. And femoral hernias which will emerge into the femoral canal, which is below the inguinal ligament. So if you're able to palpate the inguinal ligament on a patient, you'll be able to distinguish whether the bulge, whether the hernia in this region is an inguinal hernia presenting here or a femoral hernia presenting there. Now let us turn our attention to the female inguinal region. Now, almost everything that we've talked about up to this point, virtually everything that we've talked about up to this point, is the same in females as it is in males. The abdominal wall is built exactly the same way. It has exactly the same layers. The inguinal canal is built exactly the same way. It has the same superficial ring, it has the same deep ring, same layers of fascia are evaginated. All of that is the same. The only thing that's different is that in the male, what we see emerge this region. And we'll use this illustration that we used before, but we'll use it in a different way. Let's imagine that we're looking at an embryo early in its development. So at this point, it has not yet expressed itself as male or female. We don't yet know whether this will be male or female. Obviously, it's been genetically determined male or female at fertilization, but it has not yet phenotypically expressed one way or the other. So this structure that we were calling the testis before, gonadal artery, will end up in the spermatocord, which was dragged down by the testis and ends up in the inguinal canal. So that's why the spermatocord is in the inguinal canal. In the female, this would be the ovary. The ovary doesn't descend through the canal. It remains up here. It actually moves a little bit from the abdomen down to the pelvis, but it remains inside the cavity, body cavity. And so it remains inside, and therefore the caudal genital will also remain inside the abdomen and pelvis as the blood supply to the ovary. So in the female, the gonad becomes the ovary, the caudal genital ligament becomes the round ligament, the labioscrotal fold becomes the labia majora, and the gonadal artery stays inside the pelvis, and it's in a structure called the suspensory ligament of the ovary. So the only real difference, and that allows organs that should be within the abdominal cavity to be out free in the amniotic cavity, directly in contact with amniotic fluid. But that's not what normally happens. Normally it ends up fused, and this is internal and completely internalized. The other thing that can be seen here is that we see that the gut tube during its development is continuous with the yolk sac by way of a narrowed opening called the vitelline duct. So babies born with a vitelline fistula after the umbilical cord is severed will have an open communication at the level of the umbilicus with the lumen of the intestine, and so these babies will present with feces emerging at the umbilicus. So that would be a vitelline fistula. Much more frequent than that, that's fairly rare, but much more frequent than that is that when the vitelline duct does fuse reticulum, and that's not terribly uncommon. We've already talked about one modification of that gut tube, and that was this evagination that you see here. We called that the respiratory diverticulum. It grew out of the ventral midline of the gut tube, grew down ventrally and inferiorly in front of the gut tube, down into the thorax, bifurcated to form the two bronchi, and then eventually expanded to become the lungs. So that was the first modification of the gut tube that we talked about, the respiratory diverticulum. Discussion of head and neck. So for right now, what we're going to talk about is the gut tube caudal to the respiratory diverticulum throughout the entire remainder of the gut tube. Now that part of the gut tube is divided into three regions based upon blood supply to the gut tube. So what we can see here in the embryo is that there is an artery running down the dorsal wall of the embryo, and that's the aorta. And so all of this running through the abdomen would be the abdominal aorta. And we can see that there are three branches coming off the aorta that are going to be supplying the gut tube. Here's one, the celiac artery or celiac trunk. Here's the second, the superior mesenteric artery. And here's the third, the inferior mesenteric artery. Those are the three branches of the aorta that supply the gut tube. And then what we do is we divide the gut tube up into, will give rise to a variety of organs that are related to the adult GI tract. So if we look at this chart from your notes, we can see the adult organs divided up into three columns: foregut, midgut, and hindgut. And you can see that that is based on blood supply: celiac, superior mesenteric, and inferior mesenteric. And so here are the organs in the abdomen derived from foregut, and that's going to be the esophagus and the stomach and part of the duodenum, and some structures that evaginate from that part of the gut tube: liver, pancreas, biliary duct system, and so forth. Okay? Now these structures here shown in green, we said are more rostral to that. They're not part of the foregut, they're actually part of the pharynx, so we'll not deal with those now. And then, so that what we can derive from this is we know that these organs in these muscles and therefore anastomoses. And we'll talk about that later on. So what we're going to do now is look at how the gut tube develops, and we're going to do that by looking at a series of cross sections, and as we do it, we'll relate it to adult structure. Now, in your notes, there's a page with a series of diagrams that look like this, and we're going to be using representatives of each of these diagrams, but in order for us to have a better opportunity to label things and deal with it in a more detailed way, we're going to use blow-ups or enlargements of cross-sections for representing each of these. So let's start off with this one, and this is what the cross-sections are fundamentally all going to look like. So let's spend a little bit of time getting our orientation here. This is a cross-section through an embryonic abdomen, ectoderm. We're already familiar with that. The innermost layer is endoderm. We're familiar with that. And then between the ectoderm and the mesoderm, we'd expect to have, between the ectoderm and the endoderm, we'd expect to have mesoderm. And recall that the mesoderm in most parts of the embryo splits into two layers with a cavity in between. So there are the two layers of mesoderm, an outer and an inner layer of mesoderm, and a cavity in between, and that cavity we said is the coelom. And we already talked about how the coelom is what will give rise to all of the adult body cavities, the pleural cavity, the pericardial cavity, and the peritoneal cavity. So now that we're in the abdomen, the coelom will become peritoneal cavity. Now, because I want us to be able to do both embryonic development and adult anatomy simultaneously, we are going to have to pay some attention to nomenclature, because the very same structures have different names in embryos and in adults. So in order to minimize confusion, what I'll do for the most part is use the adult names even when we're looking at the embryonic structures. So instead of calling that the coelom, I'll call it the peritoneal cavity. And instead of calling that the inner and outer layer of mesoderm, I'll call it the two layers of peritoneum. In the embryonic abdomen, they can either be found inside here, where we see the gut tube, or they can be found out here, outside the peritoneal cavity, in places shown here. And I've shown a couple of representative organs here. This could be the kidney, that could be the aorta. So those are the only two places that organs could be. There are never any organs in the cavity, in the peritoneal cavity. So with that thought in a peritoneal organ, and when you have an organ such as that is partially covered by peritoneum, but not completely surrounded, we'll call that kind of an organ a retroperitoneal organ. So peritoneal organs are completely surrounded by peritoneum. Retroperitoneal organs are partially covered but not completely surrounded by peritoneum. That's between the layers of the mesentery. Pass between the layers of the mesentery. And that means it's not in the peritoneal cavity, and that has allowed it to get from a retroperitoneal position to a peritoneal position. So what we will see is that all peritoneal organs will have their blood supply reaching them by way of blood vessels that pass through mesenteries. That's what the function of a mesentery. Earlier, when we were talking about the development of the respiratory system, we said that the endoderm in the ventral midline of the gut tube in the cervical region evaginated in the ventral midline, and we called that evagination the respiratory diverticulum, and it went on to become the trachea and larynx and bronchi and the lungs. Well, something very similar to that is going to happen here in the abdomen in the distal fourth. The distal end of the diverticulum has expanded. The ventral mesentery within which it is living has spread apart to make room for it. That distal expanded end of the hepatic diverticulum is going to develop into the liver and gallbladder. That will become the liver and gallbladder. And the more proximal part of that diverticulum, the part that hasn't expanded, will be look at the relationships of these structures to peritoneum. Now, before we do that, I want to point out to you that on all of these diagrams that we're looking at, I'm showing spaces between the lines. Now those spaces don't really exist. Those lines really, in all cases, are in contact with one another. But if I drew them so that they were in contact with one another, they would look like one line. So I'm leaving spaces so we can talk about them as separate lines, but recognize that the spaces do not exist. Tube will be called the lesser omentum. That's the lesser omentum. So now we have 3 adult structures derived from ventral mesentery. We have the lesser omentum derived from ventral mesentery. We have the visceral peritoneum of the liver derived from ventral mesentery. And we have the falciform ligament derived from ventral mesentery. And as it turns out, though the liver and the falciform ligament. Now, based upon this picture, this would imply to us that in the adult, we should expect to see the bile duct inside of the lesser omentum, between the layers of the lesser omentum. And in fact, that's exactly what we're going to find. We're going to see that the bile duct lies between the layers of the lesser ligament connecting the liver to the ventral body wall. This lesser omentum in the adult is often divided into 2 portions. This much larger portion, that's between the liver and the stomach, and since it's between the liver and the stomach, we call it the hepatogastric or gastrohepatic, either way, ligament. So this part of the lesser omentum between the liver and the stomach is the hepatogastric ligament. The smaller portion of the lesser omentum, which is between the liver and actually the duodenum, transition from stomach to duodenum occurred right about here. That's where the pylorus would be. So that part of the lesser omentum is called the hepatoduodenal ligament. We said that we would expect to find the bile duct inside of the lesser omentum, and in fact it is inside this portion of the lesser omentum, the hepatoduodenal ligament. That's why this portion is a thicker ligament than this portion, because there's stuff in it. Included among that stuff is the bile duct. There'll also be the hepatic artery and the portal vein, and we'll see that later on. We also said that these 3 adult structures, the lesser omentum, visceral peritoneum of the liver, and the falciform ligament, are the only adult structures derived from ventral mesentery, because all the rest of the ventral mesentery disappeared. So if there's ventral mesentery here, but beyond that there is none, we would expect to see a free edge where the ventral mesentery suddenly ends. And sure enough, there's the free edge of the lesser omentum, marking the end of the ventral mesentery, and there's the free edge of the falciform ligament, marking the end of the ventral mesentery. So this is ventral mesentery, this is ventral mesentery. From that point on, there is no ventral mesentery. And we'll call the dorsal one the dorsal pancreatic bud. So that's saying to us that the pancreas begins its development as 2 evaginations from the endodermal lining of the gut tube. So that tells us that the pancreatic acinar cells, the cells that are secreting pancreatic enzymes, are endodermal derivatives. They're coming from these pancreatic buds. This might suggest to us, since we have 2 pancreatic buds, or pancreatic diverticula, that we're going to end up with 2 pancreases. But we don't end up with 2 pancreases, we end up with 1 pancreas. So that leads us to the question of, why is that? We see that the ventral pancreatic bud is in the ventral mesentery, but we just finished talking about the fact that most of the ventral mesentery is going to disappear. So in fact, around the embryonic right side of the gut tube. So what we're going to see happen is it'll go from here to there by migrating around the right side of the embryonic gut tube like that. So this ventral pancreatic bud, which used to be in the ventral mesentery, has migrated around the gut tube, has gotten to the dorsal mesentery, and it's now living in the dorsal mesentery. Now that the ventral mesentery is empty, two pancreatic ducts rather, two pancreatic ducts, and it also suggests to us that both pancreatic ducts ought to be emptying into the second portion of the duodenum. And that's precisely what we're going to see. So let's take a look at some illustrations to see how this develops into the adult. Here's the gut tube. Here's the diverticulum we talked about before. That's the hepatic diverticulum. That's going to the liver. You should expect the adult pancreas to have something, an appearance, something like that, sort of a hook-like appearance to it. And we also see that there are two ducts still connecting the pancreas to the gut tube. So let's take a look at the adult. Here's the duodenum. The duodenum's been cut off so we can see structures over here, but this is the second part of the duodenum, going into the second part of the duodenum, and that's called the minor pancreatic duct, also referred to as the duct of Santorini. And then because the two pancreatic buds fuse together, those two duct systems will fuse together like that. So throughout the rest of the pancreas we'll have a single duct system, but it bifurcates and empties into the duodenum by two separate ducts, major and minor, derived from ventral pancreas and dorsal pancreas, respectively. Pancreas, remember, annulus means ring, so we have a ring of pancreatic tissue surrounding the duodenum. That's called annular pancreas. So what we can say is that annular pancreas is a congenital abnormality that results from an error in the rotation of the ventral pancreas. It has nothing to do with the dorsal pancreas. The dorsal pancreas has been on the dorsal side all along, but it's the process by which the ventral pancreas gets to the dorsal side that is in error. Interesting. It really is not a pancreatic issue, because the pancreatic tissue just does the things that pancreatic tissue should do. The acinar cells secrete enzymes, the islet cells secrete hormones, and those functions are going to be carried on in the pancreas regardless of where the pancreas is. So that's not going to be the problem. The problem is that by encircling the duodenum, the annular pancreas constricts the duodenum. And okay, so that's going to become the spleen. Now, as that continues to develop, it gets larger, and if that's going to get larger, the two layers of the dorsal mesentery between which it is living has to spread apart to make room for it, very much like what we saw when the liver developed. So what we're going to see on the next slide is that this spleen gets bigger and the two layers of the dorsal mesentery spread apart to accommodate it. And there we are. So there's the mesogastrium, and we're going to give them two names also, two separate names. The part of the dorsal mesogastrium between the spleen and the stomach, we're going to call the gastrosplenic ligament, the gastrosplenic ligament. And then the portion between the spleen and the dorsal body wall, we're going to call the splenorenal ligament, splenorenal ligament. Now, for right now, that name doesn't make any sense. There's no reason apparent to us that you have damage to the spleen that's resulting in hemorrhaging of the spleen into the peritoneal cavity. You want to be able to quickly stop blood flow into the spleen. And so simply grabbing onto the splenorenal ligament will allow you to feel the pulsation of the splenic artery, and you can clamp the splenic artery in that location quite easily. Okay, so we've now completed our development of the spleen, and after we take a break, we will now turn our attention to what happens to the GI tract in those portions of the GI tract where the ventral mesentery is going to disappear, which we said is going to be most of the GI tract. So we will do that after a break. We're going to continue our discussion of the development of the GI tract now by considering what happens when the ventral mesentery is lost throughout most of the going to do, and we'll see this on our next slide, is we're simply going to take this gut tube with its dorsal mesentery and its blood vessel running through the dorsal mesentery and swing it from its present position in the midline and just swing it over to the side, taking the whole mesentery and gut tube together and just swing it over to there. Nothing else is really going to change. So we'll go from something that looks like that to something that looks like that. All that has happened is that the gut tube has moved over to the side. The dorsal mesentery has, of course, come with it. The blood supply is still running within that dorsal mesentery. Now, as a result of that, we can see that this peritoneal surface, the peritoneal surface that's covering the gut tube, in other words, the visceral peritoneum, and this peritoneal surface, which is, let me use myself as a demonstration of what would happen. If this hand represented one peritoneal surface with epithelium here, connective tissue behind it, and this hand represented the other peritoneal surface, epithelium here and connective tissue behind it, when those two peritoneal surfaces come into contact, that would mean epithelium would come up against epithelium. Now, what happens in the we're calling visceral peritoneum can't be called that anymore, because you can only call it visceral peritoneum if that was a peritoneal organ. So now that we're calling this retroperitoneal, we have to call that peritoneum parietal peritoneum. So that would now be parietal peritoneum. No longer would we call it visceral peritoneum, even though it's the exact same layer of peritoneum that it was before. Similarly, this peritoneum, which we were calling mesentery before, it was okay to call it mesentery when we were calling this visceral peritoneum, because recall that the definition of mesentery is that it connects parietal peritoneum to visceral peritoneum. But if we're not going to call this visceral peritoneum, then we can't call that mesentery, and therefore we now call that parietal peritoneum, because it's going from parietal to parietal. And this peritoneum over here has always this blood vessel that we used to say was within the mesentery and had peritoneum on both sides of it, and therefore we called it a peritoneal blood vessel. Now we would say that blood vessel only has peritoneum on one side of it, parietal peritoneum, and therefore we would call that blood vessel a secondarily retroperitoneal blood vessel. So we have made this organ into a secondary retroperitoneal organ, and the blood supply to it is by way of the name of what was the mesentery. We can't call it that anymore, so we call it parietal peritoneum, and we call the blood vessel that used to be in that mesentery, we now call that a retroperitoneal, secondarily retroperitoneal blood vessel. So it's just a sequence of name changes resulting from the death of the epithelium resulting in that fusion. So if we look at this cross-section, this schematic cross-section, we can point out 4 different organs: this piece of gut tube, the blood vessel going to the gut tube, that kidney, and that aorta. And in the adult, we would say all 4 of those structures are behind the parietal peritoneum. So we would say all 4 of them are retroperitoneal. But now we can see that 2 of them, the gut tube and the blood vessel coming to it, are secondarily retroperitoneal, and 2 of them, the kidney and the aorta, are primarily retroperitoneal. Most of the duodenum, most of the pancreas, ascending and descending colon, and the upper portion of the rectum. So these are organs that did have this process happen to it, the process that we just described here. So this, for example, could be the descending colon, as an example. And what we can say to sort of generalize this one step further is that any organ that is a secondarily retroperitoneal organ is supplied by a blood vessel that is a secondary retroperitoneal organ will be supplied by a blood vessel that is a primary retroperitoneal organ. So for example, if the kidney is primarily retroperitoneal, therefore the renal artery is primarily retroperitoneal, and so forth. So by knowing which organs are primarily retroperitoneal and which organs are secondarily retroperitoneal, we can therefore know which organs are going to be anterior to which organs. So for example, we see that the descending colon is a secondarily retroperitoneal organ, therefore the artery to it is a secondarily retroperitoneal artery. That would be the left colic artery. We can see that the ureter is a primary retroperitoneal organ. And therefore, if we say that the left colic artery crosses the ureter, which it does, the left colic artery runs horizontally across. Recall that we said that the spleen develops in the dorsal mesentery of the stomach. So the spleen develops dorsal to the gut tube. But because of that rotation, dorsal ends up to the left, and therefore the spleen ends up on the left side of the abdomen. Okay? So those are two very good examples of the positioning of adult organs based upon that simple 90-degree rotation of the foregut. Now, it has much more profound effects on other structures that will get longer, but there's not enough room in the abdomen for it to get longer. So what does it do? Well, starting at around the 6th week, it does start to get longer, and the way it's able to do that is it migrates out into the umbilical cord. It migrates out into the umbilical cord. It's getting longer, and it's finding room to do that by leaving the abdominal cavity and going out into the umbilical cord. And it forms this loop. It forms a loop of intestine, and we call that the intestinal loop. And the intestinal loop goes out into the umbilical cord. And since this is the midgut, this intestinal loop drags with it its blood supply, and we know that the blood supply is the superior mesenteric artery. So the superior mesenteric artery is running right down the center of the loop along with the intestine in order to provide the blood supply. So we have this intestinal loop and the superior mesenteric artery in the umbilical cord. And they remain in the umbilical cord during developmental weeks 6, 7, 8, 9, 10, 11, and usually by week 12, the abdominal cavity has gotten large enough to allow this to return into the abdomen. So typically by week 12, what happens is that this intestinal loop retracts back into the abdomen and leaves the umbilical cord. And it's now entirely back in the abdomen. Now, sometimes that retraction of the intestinal loop from the umbilical cord fails or is incomplete, and some of the gut tube is left in the umbilical cord. And that's what is called omphaloceal. Omphaloceal is present in babies who are born with part of the GI tract in the umbilical cord. Now, that GI tract is out there, and 270 degrees of rotation would bring it to there. So that's a 270-degree rotation. Now, in order to understand the impact of that on adult structure, let's do that again, but just look at one part of the loop. Let's pay attention to just this upper part that I'm wiggling here. The more proximal part of the intestinal loop is going to give rise primarily to the jejunum. The more proximal part of the small intestine are going to be found in the lower right quadrant. That's how they got there. Now let's do this one more time, but this time instead of keeping our attention on the loop, let's keep our attention on the more distal part of the gut tube, what I'm wiggling now, the part that's not in the loop, that's distal to the loop. But when the loop rotates, that part of the gut tube gets dragged by the rotation, as you can see. So let's see what happens. 90 degrees of rotation will drag that. Now let's turn our attention back to that first rotation and pay some more attention to the details of what happens as a result of that 90-degree rotation of the foregut. If we look at this slide, we see a slide that's fairly familiar to us. This is the foregut before rotation. We know that that's going to be the stomach. We've already said that developing in the dorsal mesogastrium is the spleen, so that hasn't changed. There it is. We said that the dorsal mesentery, or the dorsal mesentery before, is now oriented to the right. The free edge that used to be on the ventral side is now on the right side. The gastrosplenic ligament, which used to be dorsal to the stomach, is now to the left of the stomach. The splenorenal ligament, which used to go dorsally from the spleen to the dorsal body wall, still goes from the spleen to the dorsal body wall, but has gotten much, much longer, all of which are a result of this rotation. we see that the anterior wall of the stomach, the wall that used to be the left wall but is now the anterior wall of the stomach is facing the greater sac. And the posterior wall of the stomach, the wall that used to be the right wall, is now the posterior wall, that wall is facing the lesser sac. That's an important point when we have that part of the peritoneal cavity is much larger. In fact, it goes all the way down to the floor of the pelvis, whereas the lesser sac is much more restricted and only goes down a little bit below the stomach to about the level of the transverse colon. That means that an anterior wall perforation will allow gastric content to flow into the peritoneal cavity and flow all the way down into the pelvis, whereas here the content would be contained in the upper abdomen. And since the gastric content is very acidic, it's very irritating, relationship that can be seen here is the surgical relationships related to how a surgeon can get from the greater sac into the lesser sac. We know that when we open the anterior abdominal wall, that will bring us into the greater sac. If we want to get from the greater sac to the lesser sac surgically, how can you do that? Now, we know that you can pass a finger, maybe 2 fingers at most, through the epiploic foramen. So that's certainly not large enough to provide surgical access. But we can see that if we were to incise the lesser omentum, that would give us access into the lesser sac. But remember that the free edge of the lesser omentum contains 3 structures that we don't want to damage. Also remember that this free edge of the lesser omentum was the part that was called the hepatoduodenal ligament. This much larger portion of the lesser omentum was the part called the hepatogastric, here to there, and the splenorenal ligament during this rotation gets swept around to the left side like that. And we can see that in doing so, that surface of that mesentery, that peritoneal surface, is pulled right up against that surface of parietal peritoneum. And as we've already discussed, when those surfaces come into contact at the right time during development, the epithelium will die, resulting in fusion of the 2 surfaces. And so those surfaces, so that in reality, it came from the posterior midline, and it's just that the more proximal part of it fused secondarily. And as a result of that, we can now say that the splenic artery, which is in that mesentery, the proximal part of the splenic artery is secondarily retroperitoneal, but the distal part is still peritoneal. That's where you would grab the splenorenal ligament to compress the splenic artery. Similarly, the splenic vein, proximal part would be secondarily retroperitoneal, distal part is peritoneal. And since, as we'll see shortly, those 2 vessels run right along the surface of the pancreas is in exactly the same position. So most of the pancreas is secondarily retroperitoneal, and the distal part, the part that we call the tail, is in the splenorenal ligament, so that's the part that remains peritoneal. If we relate what we've just talked about to the adult anatomy and look at a cross-section, now this cross-section is oriented. This thin part of it is what we call the hepatogastric ligament. This part near the free edge, which is thickened because it contains the portal vein, the bile duct, and the hepatic artery. So this would be the hepatoduodenal ligament. There's the free edge of the lesser omentum. And as we pass behind the free edge, we go through the epiploic foramen. As we go through the epiploic foramen, we're passing from the greater sac, which is shown in yellow throughout this picture, GI tract. And from this point on, we can primarily pay attention to adult anatomy, but we'll make some references back to the embryo. And we know that the adult GI tract will be supplied by 3 blood vessels, the first of which is the celiac trunk. So here's the celiac trunk coming off of the aorta. Remember that the celiac supplies the foregut, and remember the foregut is going to be the esophagus, stomach, and duodenum of the celiac trunk. The second branch, heading off to the left from the celiac, is the splenic artery. Heading over to the spleen, we've already talked about that, and how it gets to the spleen through the splenorenal ligament. And notice that on its way over to the spleen, it's running right along the upper border of the body and tail of the pancreas. And so the The splenic artery is not just the blood supply for the spleen, it's also the major blood supply for the body and tail of the pancreas. So that's the second branch. And then the third branch, heading to the right from the celiac trunk, is the common hepatic artery. Now, the common hepatic artery is going to divide into two branches, one that ascends and one that descends. The one that ascends is the one we've already talked about. That's the hepatic artery, or sometimes called the proper hepatic artery. That's the artery that went up through the free edge of the lesser omen. So that's where the name gastro comes from. But then we also see it gives off a branch that goes into the head of the pancreas, into the head of the pancreas. And that branch of the gastroduodenal is called the superior pancreatico-duodenal artery. Superior pancreatico-duodenal artery. So it's going to supply the pancreas and the duodenum. And the way it supplies the duodenum is that there are branches that come from the region of the duodenum is right at about the junction of the foregut and midgut. The second part of the duodenum is junction of foregut and midgut. And we know that foregut will have celiac trunk supply, and we know that midgut will have superior mesenteric artery supply. Now, we've already said that the superior pancreatico-duodenal is a branch of the gastroduodenal, which is a branch of the common hepatic, which is a branch of the celiac. So that's our celiac trunk supply to foregut. If we turn our attention just for a moment to this next branch of the aorta, the superior mesenteric artery, which we'll talk about in more detail in a little while, we see that the very first branch of that superior mesenteric is an artery called the inferior pancreatico-duodenal artery. So that artery also goes into the head of the pancreas. It also sends branches through the head of the pancreas to get to the duodenum. It's simply getting into the head of the pancreas from below. That's why it's the inferior pancreatico-duodenal. But within the head of the pancreas, the superior pancreatico-duodenal and the inferior pancreatico-duodenal anastomose with a very, very good system of collateral vessels. So there's an excellent anastomosis within the head of the pancreas between the superior and inferior pancreatico-duodenal arteries. And we see the superior mesenteric artery coming down, and it's going to be giving off branches to all of the elements of the midgut. We've already taken a look at the inferior pancreatico-duodenal, which took care of the distal duodenum. And then as we come on down along the superior mesenteric, we see a whole series of branches that come off from the left side of the superior mesenteric, which collectively are of the superior mesenteric. However, notice that those arteries do not actually supply the colon directly, but rather there's a whole series of very short, straight arteries that emerge from the marginal artery, and those are the branches that go into the colon. Those arteries are called the vasa recti. Rectus means straight, the straight vessels. So the vasa recti are branches from the marginal artery that supply the colon. The important point about that is that while we said the right colic and ileocolic and middle colic anastomose very easily with one another, these vasa recti do not anastomose with one another. So each vasa recta is in essence an end artery, and it's supplying a small region of colon. So that if there was an occlusion of a vasa recta, you would have a region of ischemic bowel, a little bit above the bifurcation of the aorta. And we see that the inferior mesenteric again gives off a series of branches. We have a left colic, which is heading toward the descending colon. We have usually somewhere between 3 and 5 sigmoidal arteries, which are heading in the direction of the sigmoid colon. And then finally, the superior mesenteric ends, its terminal branch is the superior region of the duodenum and the head of the pancreas. And we talked about the very excellent collateral circulation that exists there between the superior and inferior pancreatico-duodenal arteries. In contrast to that, here in the region of the splenic flexure, although we do see communications between the middle colic from the superior mesenteric and the left colic from the inferior mesenteric, these anastomosing branches really are not very good, and they're not very reliable. So this is not a region where you get excellent collaterals. In fact, the collateralization here is pretty poor. So you cannot rely upon those collaterals in the event you had an occlusion of, let's say, the inferior mesenteric, or the left colic, because those collaterals typically are not sufficient to take over the blood supply. And it's because of the inadequacy of this region of the collateral circulation that this region of the naval system and some organs in the abdomen are drained by the portal system. So the first question we might want to ask is, how do we know which organs are drained by which venous system? And what it comes down to is a question of embryology. What we can say is that those organs that were originally retroperitoneal in the embryo are organs that will drain into the inferior vena cava. And it does not change. So when we go back and look at that list of organs that we looked at before, and these are now the adult position of organs, we can say that peritoneal organs, in other words, those organs that start off peritoneal and remain peritoneal, those organs are going to drain into the portal system. Those organs that are secondarily retroperitoneal, they're organs that started off peritoneal and become retroperitoneal, of which organs drain into which system. But now let's turn our attention to what happens to the blood flow once it drains into those veins. And if we look at this schematic here, this explains what's going to happen. What we see is that blood that drains into the inferior vena cava will get carried straight to the heart. As we know, the inferior vena cava empties into the right atrium. The blood that drains into the portal system, it also obviously has to get back to the heart with the vein. Now, the lower part of the rectum and the anal canal is a part of the GI tract that was never peritoneal. It was retroperitoneal in the embryo. They are primarily retroperitoneal organs, the lower rectum and the anal canal. And therefore, that part of the GI tract will drain into the caval system. And the way it drains into the caval system is by way of upper rectum drains to the portal. Within the wall of the rectum, there are anastomoses between the middle and inferior rectal veins on the one hand and the superior rectal veins on the other. So that means we have an anastomosis between the portal system and the caval system. And that's what we said we were looking for. We wanted to find a place where the veins would anastomose to give us an alternative pathway. Passage of blood, if the valves are competent, will only allow blood flow in one direction, that is, toward the heart. But the portal vein and all of the veins that drain into the portal vein do not have valves. So the portal venous system is a venous system without valves. And since they do not have valves, that means blood can flow in either direction through those veins, and the only thing that will determine the direction of blood flow is the pressure gradient. And an increase in pressure in the portal system proximal to the liver. In other words, the pressure here will rise. And that's called portal hypertension. That increase in pressure here will result in a reversal of the pressure gradient, and so that instead of blood flowing toward the liver, it will flow away from the liver, again remembering that there are no valves. So what we can see is that blood can flow from the portal and flow out the splenic vein, flow down, and because you can reverse the direction of flow in the portal system because there are no valves there. Now, the venous communications that exist in the rectum between the superior rectal and middle and inferior rectal are by way of the veins that are found in the wall of the rectum, the large veins in the wall of the rectum. And those large veins in the wall of the rectum are found in the submucosa. In most parts of the GI tract, shunt or portal caval anastomosis is created by portal hypertension, we're now asking those rectal veins to carry a huge volume of blood, shunting all of this portal blood over to the caval system. So these veins are going to be carrying much more blood than they usually do, and as a result of that, they will dilate. Because these veins that are dilating are in the submucosa, right under the mucosa, they will bulge the overlying mucosa into the lumen of the rectum, and these veins are now, they would be called varicose veins, and varicosities of the veins of the rectum are called hemorrhoids. So the development of hemorrhoids in the submucosa of the rectum can be secondary to the development of portal hypertension because of the use of those rectal veins to shunt blood from the portal to the caval system. So that's one important portocaval shunt, these gastric veins. The upper esophagus, the thoracic esophagus, gets its venous drainage from esophageal veins that drain into the azygous vein. Remember, the azygous vein is the vein in the thorax that drains the body wall, the thoracic wall, and it also drains the esophagus. So the esophageal veins, the thoracic esophageal veins, drain into the azygous and normally are just draining the esophagus. Under these circumstances, are being asked to carry a much larger volume of blood because of the shunting from the portal to the caval. So those esophageal veins will dilate. Again, they will bulge the overlying mucosa into the lumen of the esophagus, and we call those esophageal varices. And esophageal varices are almost always symptomatic of portal hypertension. So again, that's a portocaval shunt. In this case, it's the soup, and the result of dilatation of those veins is caput medusae. In your notes, there is a fourth listing of retroperitoneal veins, and I've left that off here because that's really not clinically important. There are no clinical findings associated with that, and it has therefore no clinical importance and not something we should be worrying about. Now we can turn our attention to the kidney, and what I'd like to do is that it can eventually be excreted from the body. So that would include the collecting tubules into which the urine flows after going through the distal convoluted tubules, and then the collecting tubules empty into the minor calyces, these small regions here. Those in turn empty into the major calyces, which in turn empty into the renal pelvis, which then leaves the kidney to enter the ureter. And so when we divide the kidney that way, functionally into filtration and conducting, that's a rough approximation of cortex and medulla. Most of the filtration function occurs in the cortex. Most of the conducting portion occurs in the medulla, but it's not a perfect match, but for our purposes, that's close enough. Now, in terms of the important things to know about the filtration portion of the kidney, that's really not a gross anatomical feature. That's something that will be talked about in medullary pyramids. And then those collecting tubules finally empty into these little recesses, which are called the minor calyces, and then several minor calyces empty into a major calyx, and then each of the major calyces empty into this even larger region called the renal pelvis, and then out to the ureter. The important point I want to make here is that as we go through the collecting portion of, or the conducting portion of the kidney, we're going from collecting tubules to minor calyx to major calyx to renal pelvis. We're going from smaller to larger to even larger structures. So the urine is passing into larger and larger and larger diameter structures. But then, when it leaves the renal pelvis and goes into the ureter, for the first time, it's going from a larger diameter structure into a smaller diameter structure. And the reason that's important is that the ureter crosses in front of the bifurcation of the common iliac artery, right at the root of the external iliac, and that's how it gets from the abdomen into the pelvis. That's important for a surgeon to know when you want to locate the ureter when doing a procedure on the posterior abdominal or posterior pelvic wall. Because the ureter is retroperitoneal, and there's usually fat in the retroperitoneum along the pelvic brim. Follow that artery up with your hand until you feel the pulsation of the internal iliac joining the external iliac at the bifurcation. We know that right at that point, right at that bifurcation, is where the ureter is going to be crossing in front of the artery. So by feeling for the pulsations of first the external iliac, feeling the convergence with the internal iliac, we'll know that the ureter is behind the peritoneum right at that point, even though you may not be able to see it. And then now that you know that, you can make an incision a little bit away from that, an incision through the parietal peritoneum, locate the ureter, mobilize it, and move it out of the field in which you are working to protect the ureter. So that's a very important point. The other point to take note of is that as the ureter is descending in the abdomen, it's lying right on the anterior surface of the. Let's turn to the development of the kidney and return to this image that we looked at the very beginning of our discussion when we were talking about the formation of germ cells in the gonad. At that time, we pointed out that in the early embryo there is a ridge of mesoderm on the posterior abdominal wall, and you can see it's a very long ridge of mesoderm, and we called it the urogenital ridge. And we said part of that urogenital ridge is what's going to become the gonad, and we talked about that at that time. And the remainder of this much larger portion of the urogenital ridge, is going to have something to do with the development of the urinary system, development of kidney. So what we have is this very long ridge of mesoderm, it's sometimes called intermediate mesoderm, just lateral to the somites. And that intermediate mesoderm is going to form kidney, induced by the mesonephros, and will carry that urine all the way down and empty into the most caudal end of the gut tube, the part that's going to be called the urogenital sinus, which will then open to the exterior through the cloaca, which is what will eventually become the urogenital openings in the embryo. And so that urine is able to get out of the embryo. Urine produced by the mesonephros goes into the mesonephric duct, into the gut. Since this fetus, embryo and then fetus, is putting urine out into the amniotic cavity continuously, pretty much, this fluid has to go somewhere, otherwise the amniotic cavity would just get larger and larger and larger and larger throughout pregnancy. So what happens is that the fetus swallows the amniotic fluid. So, and that's an important part of the development of the GI tract, that in order to develop the swallowing mechanism, we lose the mesonephros. The mesonephric duct, which was being used to conduct urine from the mesonephros, is retained in males. And in males, its function is converted over to a genital tract function, and it becomes the ductus deferens. So the mesonephric duct in males becomes the ductus deferens. Remember that the gonad was developing right next to where the mesonephros was developing, so that kind of makes sense now, that the